Hi, everyone. Thanks for joining. Let's start to go through just a few LV cases further to what we were talking about last week. So, Drew, you're the one I could see first of all. Let's just start with this, okay? So you've got a 65-year-old male. They've had a STEMI, urgent cath. They've found 100% LAD occlusion. And this is the echo that we were doing the next day from the CCU. It's had a little bit of hypotension, and that's why we're doing the scan. So let's just go through these. Tell me about your findings and what walls we're looking at in the LV in particular.
Okay, so we can see the anterior septal wall, the inferior lateral wall.
Yeah.
The anterior septal wall appears hypertrophic, although I'd want to measure it formally. The inferior wall doesn't appear thickened, therefore it's most likely asymmetric. The walls are contracting normally in this view. The left atrium is dilated. The aortic valve appears competent, has good excursion, and the right ventricular outflow tract is not dilated. I can't appreciate a pericardial effusion.
Cool. Okay, we'll keep going. Nice job on the walls. Let's see if this makes it any clearer.
Okay.
Actually, not really. I don't think we've got great pictures here. It's still not quite possible. Have a go. Go for it. LAD territory is 100% occluded, remember.
LAD 100% occluded. So I guess focusing mostly, I'll look at all the different views, but at the papillary level, the mid-ventricular level, there's some dropout in the inferior septal wall. So difficult to interpret that, but the other walls do appear to be contracting. Well, perhaps subtle hypokinesis in the anterior septal wall.
Nice.
That I want to interrogate,
nice.
but very subtle, very subtle. The same thing that you can see in that top right corner as well.
Okay. I'm going to show you tips and tricks and see if I can do it online about this, actually. Hang on, let me just grab this one in particular. Let me just put this in a new... actually, let's add slide here. I'm going to see if I can show you how to do this online. It'll be a miracle if I can. Okay, so if you're looking at a short axis like this, one of the things, if you can do it, and I bet you it won't let me do this, I want you to now imagine, and I literally do this in my echo reporting, is I'll try and cover up half the... Why don't we make it a different color so it's not quite so obvious? So I'm going to cover up half of what I look at. I literally put my hand on the screen and just look at those three chambers. Just look at those three segments. So we've got our anteroseptal, anterior, and then maybe if I sort of do it a bit more like that. So anteroseptal, anterior, and anterolateral. Just keep those in your head. And I know these is a real case, obviously, so sometimes the pictures aren't great. And then let's going to try and compare that to the other side. And when you look at, and it's not the greatest case in the world, actually, I've chosen, isn't it? But just, I think you get the idea that you're right. There is subtle differences in the thickening, which is hypokinesis, and it's really important to show. Once I've done that, and I can take that out of the cage, I can then try and compare it like a clock face. So I'm going to compare, say 1 o'clock with 7 o'clock. I'm going to compare 9 o'clock with 3 o'clock. I'm going to compare 11 o'clock with 4 o'clock. And that's how you can pick up subtle changes, because there are subtle changes here, and maybe they're not coming out beautifully across the internet, but that's the kind of tip and trick I'd have for trying to pick up subtle changes. I think giving it to you on a tiny screen at home is maybe a bit tricky, but one of the things I was trying to get you to see, which I think it is, and again, it is subtle, is that first of all, the myocardium does look like it's thickening less than 50% and not as well as the other areas in that anterior portion. So that's going to be the anteroseptal anterior area of the basal, mid, and I haven't really given you a decent apical, have I? But those areas are hypokinetic, but they're also thickened. And so my question to you was going to be, how can you tell the difference between acute regional wall motion abnormalities and chronic?
So like in a transmural infarction, you'll expect thinning, echogenic, like an echogenic wall, and even some events of aneurysm. It can be dyskinetic, those walls as well.
Yeah. You say transmural. I mean, I think it's because you can get transmural infarcts that are acute, though, because that's what I think this patient's got.
Sorry, it would be more, I think it meant more like scarring.
Yeah, nice.
That wasn't
Fantastic.
the right term. Yeah.
So chronic is scarred, thinned, akinetic, can be dyskinetic, whereas this is a really great example of someone with acute, significant infarct where you've got some thickening happening, but it's edematous. It looks a bit bright to me, and this can be a sign of someone who's had a rip-roaring infarct, and it can obviously be subtle in between. How about this?
What walls? Seen these ones.
Say again.
I feel like we've seen these pictures.
I know you have, probably.
Oh, okay.
But
okay,
this is right. Anyway, we're gonna come on to this is from I did use these for a little video we made a while back.
All right. Yeah. So keep going.
Tell me the walls.
Yeah. Okay. So we have our anterior lateral and our inferior septal walls. I guess the key findings are akinetic apex.
Yeah.
With spontaneous contrast. And I think that
beautiful
hypokinesis of the inferior septal kind of region, as well as the anterior lateral, sorry.
Beautiful. So we're dealing with, and if they were hypotensive, what are your thoughts behind that? Because again, this patient, as we said at the beginning, was hypotensive.
Yeah, well, I guess I would be looking for the mechanical complications of a myocardial infarction. Paying attention to look up, so like cardiogenic shock, so a reduced cardiac output, stroke volume.
Very good.
Any evidence of like a rupture of the free ventricular wall that we haven't appreciated.
Very cool.
So those probably be the structural stuff.
So you got the rupture, so they're just mechanical complications, and I think Santosh would have gone through that sometime before, which is you talked about, you kind of ischemic papillary muscles blowing out. That's particularly with the circumflex coronary artery territory occlusion, taking out the posteromedial papillary muscle. You can have VSDs, you can have cardiogenic shock, and maybe we talk about Dressler syndrome. So those would be the common complications, right? So let's pretend we're dealing with some cardiogenic shock issues with this guy, with this hypotension.
Yep.
So this is one of the easier ones to try and describe. If we look at this amazing new software I've been playing around with called Harvey Online, and we'll look at some of these pressure volume loops. And one of the things that we can change with these pressure volume loops are just trying to remember that we've got this slope, which is known as the end systolic elastance, if you like, or end systolic pressure volume relationship. And then the one at the bottom, which is the end diastolic pressure volume relationship, that is a marker of filling and where we got diastolic function coming from, and left atrial pressure estimations. You'll note that we've got for the end systolic elastance, that's just a linear line as opposed to the end diastolic pressure volume relationship, which has a curved format to it. So with this case, with the cardiogenic shock, if we take, so let me just quickly change this down to just a basic LV. If we reduce the contractility, such as this patient who's having cardiogenic shock, you can see what happens to their ejection fraction in particular, stroke volume, and wedge pressure. Okay, so the stroke volume is made up from going from one side of the pressure volume loop where you're at the beginning of systole, and you compare it to the beginning of diastole. And it's that difference between those two lines to the stroke volume. So as that patient goes into cardiogenic shock, the stroke volume went from like 89 or whatever it was down to 68, went down by 20%. The ejection fraction went down from, I think it was 70 down to 50. And the wedge pressure went up from, I think it was 12 to 18. And so you see the wedge pressure is that mark just down there at the bottom right of the image. And so my question to you, Drew, is how do you fix that? So if you've had that problem and someone is hypotensive, what happens if you give this patient fluids?
So it depends if they're fluid responsive and not. In this case, they're not. So
And
what it
how do
would
you
end
know
up,
they're not fluid responsive? Because you're absolutely right. Because look what, because let's say I give this guy a liter of fluid. You're doing that because you want to improve his cardiac output, right?
yep.
And if we want to improve his cardiac output, we'd see that with a stroke volume that goes up. His went from 68 to 69. We've got an ejection fraction that hasn't changed much, but what has gone up?
End diastolic volume.
Yeah, nice.
Yeah.
So I think it's a really nice way to describe this patient that doesn't respond well to preload. And I think the only way that you could start determining whether this guy, oh, see, maybe you've got a stroke volume that has gone up a little bit. But I think these are, I take this, what I've taken away from this example when I've been playing around with this is this idea that if we're saying that this patient potentially maybe might have been fluid responsive because we went from what did we go from 66 to 75? But what's really interesting is I think we should be looking at our diastology with this as well. I don't know whether we'd have a max pressure of 43.
Yeah, yeah.
But
they're in a lot of trouble.
But I think if we're assessing patients with cardiogenic shock and we're giving fluid to them, we've got to be looking at their diastolic functions as well. And I'll start trying to find some better examples of this when I've got a bit more time. But I think the best way we've got of doing it. So if you had to choose, let me just put him back to how he was. Actually, I'll just do this. Let's go back to normal. Let's give him a terrible cardiac function. What happens if one of the things we often hear from cardiologists when we've brought patients down into the ICU is why we've stuck them on noradrenaline. So what do you think if we put this guy on noradrenaline? That would just massively increase up his SVR, right?
No, like it has some beta effect as well. So it's not the worst choice. Not the worst choice.
So if to give him some noradrenaline, I'd turn up the SVR a bit and I'd increase up his function a little bit. And you can kind of see from the two markers what that first thing has the potential of doing there, which is reducing your stroke volume though. So physiologically, you can understand why increasing up afterload might not be the best thing to do for someone who has a cardiogenic component to their shock. Because what we're going to do and try and show in a minute is there's going to be a balance if we can try and describe what someone in septic shock will look like who doesn't have a cardiogenic component to it, and then someone who does. Yeah.
Yeah, and like cranking up that SVR too much can lead to a lot of complications as well.
Yeah, very nice, very nice. Okay, so maybe just quickly to summarize what we did just there. So what I was trying to show is someone who's normal, who then goes on and has a heart attack, is the equivalent of dropping their contractility by about half. Whoa, not that much. So if we drop their contractility, you get a reduction in your stroke volume, you get a reduction in your ejection fraction. The way you sort that out is to unblock a broken coronary artery and potentially give them dobutamine would be the classic thing to do. Particularly if they're on this upstroke of their end diastolic pressure volume relationship though, if you start giving this patient too much fluid, you may increase their stroke volume, but you're also pushing them further up that raised end diastolic pressure, raised left atrial pressure area. So you've got to be careful.
Downstream complications.
Very nice.
Or upstream complications.
Right. I never quite, I'll be honest, I never quite know whether it's downstream or upstream.
Yeah,
it's upstream.
Upstream.
It's upstream complications. Yeah.
Yeah.
Okay, let's go back to normal. And let's have a go. Is there anyone else who wants to have a go at the next case? Let me see what I've got. Where did I put it? Okay. So case 2. All right. Who else have we got? Damien, do you want to have a go at this next one?
Yeah, sure. Go for it.
Okay, nice quick one. So this is a 25-year-old man, 25-year-old man, 2-month history of shortness of breath, pitting edema to thighs, hypoxic with basal craps. No other past medical history, minimal ETOH use.
So parasternal, long axis, the most obvious abnormality is that there is gross hypokinesis of left ventricle. I'm looking at anterior septor and the inferolateral walls. Doesn't seem to be, in this view, regional wall motions. It seems to be a fairly global process. And there's probably a suggestion in here that it might be biventricular. The right ventricle looks slightly larger than I would expect. Left atrium looks slightly enlarged, and I would guess with this gentleman's LV that he'd have high filling pressures, so that's consistent with the picture so far. But interestingly, he doesn't have a huge number of B lines in the imaged lung fields.
Yeah, nice. What can you see in the lung fields?
So it almost looks consolidated. I'm not.
Nice.
I'm not quite sure if it's just my image here, but
no. Well done. Well done. I agree.
There's not an obvious sliding pleural line, and it looks fairly heavy.
Do you know the term E-point separation?
Yeah. So this.
What does that indicate?
Point separation is going to be significantly more than 1.3. So he's going to have. And that would be consistent with poor contractility and poor excursion of the anterior leaflet towards the septal wall.
Okay, you got 1.3 because I had 7 or 8 millimeters in my head being associated with, if it's greater than that, being associated with a cardiac output of 4 liters per minute.
Yeah.
So
I'd have to look at.
I'm sure there are different things. Yeah.
Yeah. I thought something like more than 1.3 was associated with an EF of less than 30% or something like that.
Nice.
7 is round about your cutoff or something. Okay, so this is a apical 4 chamber, and this supports what we've seen in the previous parasternal long axis. There is a global hypokinesis of the left ventricle. There is a significantly enlarged left atrium with the suggestion of bowing towards the right side. I can't entirely see all of the right ventricular free wall, but the TAPC looks preserved and almost looks hyperdynamic. And that's not supportive of what I was suggesting I could see in the previous parasternal long axis. So the right ventricle doesn't look particularly enlarged here, and it looks like there's preserved longitudinal function.
So if you've got a bad LV, talk to me about the upstream features of that.
Yep. So the upstream features of that is that I've got an enlarged left atrium. I've got evidence of high left atrial pressure in the 2D views. I've got bowing of the left atrium towards the right side. And you know, we've looked for the B lines in the lung, which we can't see, but I'd be interested in looking at mitral regurg and EA filling.
Yeah, nice.
Okay, so I'm going to start with the EA filling, if that's okay. So looking at transmitral filling, sorry, this is a bit small for me. I can't see a value. The E wave is 1.
Yeah, so we've got 1 versus 4. So what does that make it? It's greater than 2.
Okay, so that supports the fact that there's predicted high left atrial pressure. You've got an EA of more than 1.5. Although your E wave is not more than 1.2, but the EA ratio is still elevated. We've got a parabolic. Is this mitral?
What's the E? You said the E wave is not greater than 1.2. What is that? Why did you say that?
Sorry, because I thought the one below was mitral regurgitation.
Yeah, fantastic. Yeah, just because if you're looking for the severe MR.
Yeah. So I've just seen it's actually over the tricuspid. So there is a EA ratio that's elevated. There's a tricuspid regurg of 2.9. So that's just about over the cutoff value of 2.8, 2.9 you'd look for evidence left atrial pressure. And in terms of the tissue Doppler the top one is that lateral? Sorry, I can't quite see.
That is, I can't really see. Yeah, the top one is lateral, and it looks like it is at, say, call it 7. And then the bottom one is medial, and that's at 5.
Okay, so those are reduced, so
Yep.
consistent with poor mitral annular excursion.
Yep.
And the systolic wave laterally is less than 10.
Is
So
way less than
again,
10. Yeah, it's at,
Yep.
it's call it 6.
6. So again, consistent with a globally poor left ventricle with elevated left atrial pressures.
Yeah, very nice. So we've got severe diastolic dysfunction with raised left atrial pressures. Very nice. D cell time is another one that as I was saying last week, that I like using. Sorry, one second. So if it's close to 140 or 160 is sort of the magic number for thinking about severe restrictive filling. And if it's sort of above 240, then that's normal. So the D cell time would be another one. It would have been nice to have given you. So what are you taking away from all of that?
Mainly that it's consistent with his clinical picture.
Yep.
So he's coming with progressive shortness of breath. He's got evidence of a backed up system with pitting edema peripherally and progressive shortness of breath. It's interesting we didn't see B lines given the fact that he came in with shortness of breath and evidence of biventricular failure with pitting edema up to his legs. But it supports his underlying clinical picture.
So if I was going to try and describe his situation then in this one, this guy's also going to have some reduced cardiac function like the last one. But along with that, he also looked like he had some remodeling, because one of the things we didn't talk about was the size of his LV. So in that first case, that was a guy with acute systolic dysfunction. This next guy is someone that looks like there's a chronic component to it. Because one of the things that he had was, if I've given you the numbers a bit better, was hypertrophy. And he also had a bit of a dilated left ventricle. So that means that he's going to have some kind of remodeling done, which with that hypertrophy and that dilation means that this is how he protects his stroke volume. So that slope of the curve goes down. And with his dilated cardiomyopathy giving him that global picture, the capacitance of that left ventricle increases. And that means that he might have a ejection fraction is low, but he's still got a good stroke volume and he's still got a reasonable cardiac output because of the remodeling that's happened to his ventricle. Yeah. So how would you say, now let's say that guy is hypotensive for whatever reason, such as septic shock. So if he's got septic shock, he would have a reduced SVR, right? What do you think is going to happen to his blood pressure when he does that? If he starts getting septic shock, what's the way that you look to try and resuscitate him?
So as in, if he's got septic shock, his afterload will be low, and paradoxically, his ejection might improve a little bit. But I'm imagining somebody's going to give him a couple of liters of fluid, and
yeah, and one of the things you can see is this blood pressure drops, but his cardiac output goes up.
Yeah,
absolutely. So I guess what I was kind of the idea of is, if you give this guy fluid, what do you expect is going to happen?
So you'd expect his left atrial pressure and his wedge pressures to go up even further, because he's going to be fairly poorly tolerant, but there's going to be a balance there between his afterload and his improved forward flow with vasodilatation.
Yeah,
But
really
you'd expect
nice.
him to become a bit more overloaded and to come to a less favorable part of his Frank Sterling.
And there's a balance, right? Just like you said, because you see that the stroke volume, the blood pressure certainly increases as you give this guy fluid, but it's also as left atrial pressure starts going up, and then when you reach a certain point, it starts to go up and up and up and up and up. So how do you find that balance? Would be my question. What do you think?
Serial EAs.
Yeah, nice.
Serial LVOT VTIs to work out where his cardiac output is and whether you've pushed him into a non-compliant part of his Frank Starling curve.
I think you're going to see the stroke volume. He may be fluid responsive. If you look just at his LVOT VTI, he may be fluid responsive in there. I just think you've got to do it in accordance with his with looking at his wedge pressure.
Yeah. So based on last week, that would be EAs for him.
Yeah.
And then I don't know,
B cell times, and I think the E2E prime. So next question. What's the let's go to the last bit that he had hypertrophy, right? So let me just go. I'm just going to get him back to how he was normal. Let me put in presets normal. Let's freeze that. Let's make him down to 1. Get his lusitropy down to 0.2, and then go. Okay, so that's how he was. Maybe not quite that bad. So that's him with his reduced cardiac output. One of the things that I was wondering that these guys also don't tolerate is, tell me what the E prime indicates to you.
So the E prime is the degree of relaxation of the myocardium. So it's
nice.
How it moves away from the annulus as it relaxes.
And what are the units of that? You say it's how fast it moves. So we're doing that with tissue Doppler. So what are the units and what's the scale?
So it's slow movements of the myocardium. So it's in centimeters per second.
Beautiful. So here we've got it down in centimeters per second or meters per second, just 0.06, as opposed to flows which are through pulse wave Doppler, and we're looking at flows in the mitral inflow, which is up at 1. Nice. So you're looking at speed, and so the E prime is looking at the rate of downward motion. So if that point there, that rate of downward motion of that mitral annulus. And what that's meant to be in the best indicative of is tau. And tau is the measure that they've used in all these animal experiments of rate of relaxation. Now with that guy there who's probably had this dilated cardiomyopathy, he's had it for a while. That's why the left atrial pressure is elevated. That's why the left atrium is big. This guy's got quite a large tau. So if I was to say put this tau up to 40, what do you think that does to his pressure volume loop? And I'll let you watch it as I do it. It doesn't change it at all. Okay. So it's the rate of relaxation. So one of the things that I've been I'm just having a think about this week, going down this rabbit hole, is you're saying you want to look at the E to A ratio, which I think you're absolutely right. Well, we can look at the D cell time, which I think is absolutely right. But one of the things that stays relatively fixed, even though we look at it across, when we look at it across different time variables, is the tissue Doppler. And the tissue Doppler is the rate of relaxation. And the rate of relaxation is very, very much affected by heart rate. So I think this is one of the things I really like about this model, is that this is maybe talks about the way these guys tolerate tachycardia. I'm really sorry, I'm on call, just hang on a sec, excuse me. Sorry about that. One of the things that the E prime is indicative of is tau, which you'll see that the what I changed before in terms of the lusitropy was the end diastolic pressure volume relationship, whereas tau is the rate of relaxation of the LV. And what tau is very sensitive to then is heart rates. And one of the things I was trying to start thinking of, which is all Drew's fault with this, in my opinion, is then trying to think during this week about what patients might be intolerant of fluids, but also intolerant of fast heart rates. And this guy's heart rate is not that high at the moment, but as it goes up, this is the guy that will start to fall off the edge because he won't fill his ventricle well at all. So as he starts off at the beginning, if his heart rate's not high, he might be okay. But as his heart rate gets faster and faster, these are the guys that then go into a greater cardiogenic shock. Do you think that makes sense? Do I describe them that well enough?
Yeah, Sam, can I ask
Yeah.
you then? So we spoke last week or the week before, I can't remember, about Michel Salama's paper about filling pressures in different subgroups of ejection fraction.
Yes.
So they showed that the EA was the most sensitive for patients with
Absolutely.
reduced ejection fraction, whereas a lateral E-wave wasn't.
Yes, very good.
So
Very
how
good.
does that fit into your thinking about this?
Because I think the EA is probably one of the most sensitive markers, and I'll try and get my language right, most sensitive markers for raised left atrial pressure. But E prime is going to be the most sensitive marker of, or maybe say it's the most specific marker for diastolic dysfunction. And that's different, right? So I think the diastolic dysfunction, the E prime, is all about the rate of relaxation. So that's going to be about how tolerant that patient is of both fluid overload and tachycardia. Whereas the E to A ratio is probably most sensitive for picking up raised left atrial pressure. Because you can have diastolic dysfunction, but a normal left atrial pressure because it's dependent on preload. But they're not going to be that tolerant of it, of being fluid overloaded, I mean.
Yep.
I think that's what I'd say about that. Drew, what do you think? And Sean?
I was gonna throw out something a bit weird and say maybe diastology is like a ventricular atrial uncoupling, and that's one way to thinking of it.
Sorry, tell me a bit more about
that. The way that the left atrium, so diastology is, so coupling is the matching of one chamber to another, and if you have reduced compliance of the LV, then its ability to accept fluid from the left atrium is impaired.
I love it. So the worse your E prime would be, the more uncoupled it is, or the more, or the less tolerant you'd be of any kind of overfilling.
Well, it's of diastology. I take the point that I think in the critically ill, at least in that hemodynamic book of critically ill, that they think that say that the E prime is probably less reliable, and particularly the E to E prime. They look at like different parameters is my understanding of it.
Mm-hmm.
And I think it's because of the altering in the velocities of the tissues, Dopplers in critically unwell patients. But I could be wrong about that. I wouldn't claim to be a
yeah, I'm not sure the literature is good enough to say it's perfect on that yet. But I think one of the things that using any of these as a static measure probably I think is the fallacy in this. You've got to be looking at the change over time, and that will give you much better accuracy about where these people are in terms of their tolerance. And if you're seeing that change, you'll pick it up.
I think this comes back to, I asked this question last week, and I'm not sure there was any information on it. Is there any information on how your E prime, changes with fluid loading, and whether like tissue edema and interstitial edema
Yeah,
changes?
it's a great question. I'm not that I know of. Let me look into that, but I don't think I've seen great literature that talks about a lot of changes in these diastolic parameters with time. And I think it's something we should probably have a look at. Anyway, is anyone up for another? Should we try another case?
Yeah, sure.
Sorry, Drew and Damien, you're the guys, the only one with the camera on. So, Drew, have a think about this one. Drew says 74-year-old female, day 6 in the ICU for PJP pneumonia. Background of rheumatoid arthritis on methotrexate and pred. So she's immunosuppressed, and that's how the PJP happened. We've put a previous TE showing mild regurgitation. Okay. Day 6, she's on single strength NORAD. She's got a negative fluid balance of 2 liters. We've got a driving pressure that's okay, giving us decent tidal volumes on minimal levels of oxygen and minimal levels of PEEP, and she's looking towards extubation. When we've tried a spontaneous breathing trial on her, despite the chest x-ray looking better, she becomes worsening tachycardia, hypertension, hypoxia, and bilateral infiltrates. Okay? So we did an echo on her. Take us through this.
Okay, so it's essentially a situation of a patient who has failure to wean, and we want to estimate the left atrial pressures and try to inform the probability of systolic dysfunction or left heart failure in some degree. This peristernal long axis, the left ventricle subjectively looks dilated. I'd want to look in different views and measure it, particularly by biplanes, and assess the volume. The contractility of the anterior septal and inferior lateral walls do appear preserved in this particular view, but I would want to look in other views. Subjectively, the left atrium doesn't appear significantly dilated. Aortic valve appears normal. The mitral valve appears relatively normal. There might be some billowing of that posterior leaflet. I'd want to assess that with color. And the right ventricular outflow tract shows fairly normal contractility in that area.
Yep, cool. Okay, we'll move on.
Okay, so you can just see some, you want to quantify it in multiple different parameters, but it is appropriate Nyquist limit, probably mild to moderate, maybe more in the moderate posteriorly directed mitral regurgitation. And I do wonder if there's perhaps maybe some tethering of that posterior
really nice.
leaflet. That's
It's
the
just beautiful.
etiology.
I think if ever you're going for any kind of moderate regurgitation of the mitral or tricuspid valve or aortic valve, you've got to be able to describe the mechanism. So excellent. Whenever you've seen moderate, tell me why. And if it's posteriorly directed, tethering is the most likely one. Yeah, very nice.
Okay, so I guess this is the benefits of different views. So I can see the anterior lateral and inferior septal walls. The ejection fraction is globally reduced. It's slightly foreshortened in the second one of the. It's probably around 40% on the moderate range. The left atrium does appear dilated in this view. The right ventricle is maybe mildly dilated, but the tricuspid annular plane excursion appears within normal range, and the right atrium visually looks normal. So at the moment, I don't have a good explanation for this patient's failure to wean, but I would want to interrogate that mitral valve a bit further.
Okay. Give you an ejection fraction here, which we thought was mildly impaired at 44%.
Okay.
It's a bit more easy. You call that moderate MR. So what information did you want in addition to what I've given you so far to determine the severity of the mitral regurg?
Yeah, so evaluating the severity of mitral regurgitation is a multimodal process. First, you look for 2D for non-coaptation flail valve. You look at color for a PISA, so a flow convergence greater than 1 centimeter, and that's at a Nyquist limit of 30 to 40. Look at the vena contracta greater than 0.7. That's at a Nyquist limit of 50 to 60. and a greater than 50% filling of the left atrium with the jet. Pulse wave through the leaflets, you look for a E inflow greater than 1.2 to 1.5. On continuous wave, you look for a dense jet, potentially a V cutoff sign. Pulse wave through the pulmonary vein would show systolic reversal. Then I perform quantitative methods in a moderate severity MR. The values I'd be looking for would be a regurgitant volume greater than 60, regurgitant fraction greater than 50, and a effective regurgitant orifice greater than 0.4, or greater than 0.4 centimeters.
Nominal, Drew. Great job. Great job. That's exactly how you do it, and do that in the exam. That was absolute gold. Well done. Okay, so there you go. There's your continuous wave Doppler supporting your theory about moderate.
Yeah, it's a it's not a dense jet, but it is a complete jet.
And it's complete jet, not quite as dense as the forward flow. I very much agree with moderate.
Yeah, this would be in keeping with moderate as well. We have systolic blunting, so S wave is smaller than the D wave.
So putting that all together with the left atrial volume that's greater than 34 mils per meter squared, where would you put the left atrial pressure after all of that? I didn't give you the 2D pictures, did I? Sorry, I didn't give you the E/TIA ratio. Where's that gone? Oh, there you go. Sorry.
Oh, yeah. Okay, so E is 1.5. Yep. E to E prime is 14. Okay. In it, I guess what I would say is in a mechanically ventilated patient, an E to A greater than 1.5 is fairly specific for elevated left atrial pressures. So I'd be saying that this patient needs some diuretics and a reattempt.
Particularly with someone who's got a bit of a low ejection fraction as well.
Yep.
Yeah, very good. Very good. So diuretics, and so you've told me the severity of the MI is moderate, the left atrial pressure is elevated.
Yeah.
And so further management, diuresis and repeat echoes. What would you think this patient would be ready for extubation?
Yeah, so I'd diurese him. I'd probably extubate him onto bilevel or onto CPAP, non-invasive ventilation. And on repeat echo, what would make you think they were ready for extubation? Evidence of E to A that was reduced, particularly an E to E less than 10, or less than 10, would really start making me think that this patient was trending towards extubation. And a lung ultrasound could help too if you thought that the ARDS had resolved.
That's really nice. It's really nice. Okay, so take me down to this lady. So she's got, so we're just going to mimic her, try and help me out with what happens when she's on mechanical ventilation and then what we're going to do to get her off it. So she is a lady who's got some raised left atrial pressure. So she's got some diastolic dysfunction. So that means I'm going to raise her end diastolic pressure volume relationship. She's got a little bit of a reduced systolic function. Maybe not quite that bad. And she's got a bit of extra fluid on board. Yep. So she's going to have a stroke volume that was needing some support. She's got an ejection fraction that was 44%. Maybe I haven't got it quite right. And then we put her on a ventilator. And what does a ventilator do to this woman?
So it's going to reduce her preload and reduce her left ventricular afterload, but increase her pulmonary vascular resistance. So it'll mechanical ventilation, positive pressure ventilation will improve her hemodynamic state.
Very nice. Very nice. So we can see it's going to reduce her preload. It's going to reduce her wedge pressure. We've reduced her afterload. And we've reduced her preload and reduced her afterload. So what we should have seen is hopefully a little bit of an increase in her stroke volume and cardiac output and reduction in her wedge pressure. Nice. And so what does removing her from the ventilator do? So weaning from the ventilator would do the opposite, right?
Yep.
So it's going to increase up her preload. It's going to increase up her afterload, and that further reduces her stroke volume. Yeah. And bumps her up the left atrial pressure.
Wedge pressure would go up.
So what you're suggesting that we then do is we are going to try and pull her back from this area by unloading her, and that's going to pull her back down closer towards extubatable levels and reduce her left atrial pressure.
Yeah, and then some CPAP could help with that too.
Yeah, nice. And CPAP will help with just a little bit of the afterload reduction. And so as we do all that, that should improve her stroke volume over time. Does it work? Sort of. Yeah, it's awesome. Thanks, guys, for letting me play around with this. I'm still trying to get my head around it a bit, but I'm hoping it might be a nice way to start trying to explain some of these hemodynamics. Okay, so quickly just finish off the case for me. Where'd it go? Okay, so we diuresed her further 2 liters, extubated her to CPAP successfully. So what would you expect the changes then to be in what you've looked at? So the moderate MR, what's going to happen to that? Sorry, you're on mute, Drew. Drew, you're on mute.
Sorry. This is a tricky one, but because the LVEDP I'd expect to reduce, and because color is a reflection of gradient changes, I'd expect that the MR shouldn't. I'd expect for it to get less severe, but also acknowledging that as the LV function improves, it may generate more of a gradient and may make it look more severe.
Lovely comment. Lovely
I
comment.
don't know.
Yeah, lovely comment. I mean, I think you're probably going to have increased afterload, so it could get worse. It could get better. Yeah, I think it got. What about the left atrial pressure?
Left atrial pressure after diuretics, I'd expect to reduce.
Yeah, nice. And that's what we can see here with the blunting of that S wave on the S in the pulmonary veins has improved, and now we've got a normal SD ratio. Very nice. And then if we look at the E wave, it's reduced in volume because it's preload dependent. So with the diuresis, it's preload dependent. The E to A has come down accordingly because the left atrial pressure is hopefully less. The E to E prime is reduced. It's not so much the E wave velocities as much as the E wave velocity that's coming down. Left atrial size is smaller just by a little bit. TR is down, and both of the jet severities have improved. Yeah, good job. Good job. I think we went through this last week talking about these left atrial pressure estimates. And again, I think the repeated assessment is the bit that's super useful, as well as taking into account their clinical status. Guys, I might have to call it there, I'm afraid to say. I've got to get going to another meeting. I hope that was useful. Thanks again for letting me try out this new software, Harvey Online, but I hope I'm going to try and find a way to try and link up some physiology with echo analysis to try and make sense, and hopefully we can go and try and consider the next thing about how to assess left atrial pressure and repeated assessment. Are there any questions?
No, it would be awesome if you could get the inflow waves and stuff superimposed on the Harvey. That would be amazing.
Oh, I love it.
That was really helpful last week.
Yeah, nice. Yeah, I'll see what I can do. I don't know about that. That sounds challenging, but I'll give it a go. Thanks very much, guys. Are there any other questions?
Thanks so much.
Is Harvey a paid website? Yes, Harvey Online, but it's not super expensive. I think it was something like for one user, it's something like $100 US or something a year. So yeah, it is a paid website. But yeah, Harvey Online, I still think it's pretty good. All right, nice to see you guys. Take it easy. I'll see you next week.
Thanks, Sam.
Yeah.